understanding injectable anatomy. So every time you pick up a syringe of whatever and you start to put it in that person's face, you are going to envision what is underneath the skin. And I think particularly important for dermatologists, because many dermatologists aren't surgeons and don't open it up and aren't familiar with what's underneath the skin. And if you don't know the depth of the vessels imprinted on your mind, it'll be very difficult for you to inject, I think, with a sense of safety and security. All right, so let's start out here. I'm going to see what kind of markers they have for me. Oh, let's try this one. All righty. Oh, good. Eyeliners. Okay, good. Now, what we're going to start with, we're going to start upper third. Now, please feel free if I say something you want to augment. We're going to start upper, middle, lower third of the face. So when we start in the upper third of the face, what I like to do is first think about where is your supraorbital notch. Everybody can feel that? Here's your supraorbital notch, so we're going to mark that supraorbital notch. And why is this important? This is important because this is where the supraorbital artery and nerve exit. And when they come over the orbital rim and go, I want you to be able to see this, and go superiorly, okay?
I think if we maybe, I'm just watching the screen, and we could probably just, there we go, good.
Okay, so is that better?
Yeah.
Okay, good. I'll rotate myself.
Perfect.
Okay, so as we come, this supraorbital artery has little collaterals, right? And it's very deep here, and a centimeter and a half above the orbital rim, not the brow. Don't be fooled by brow placement. Bony landmarks are what are important. So as it comes a centimeter and a half above the orbital rim, this supraorbital artery pierces superiorly through the galea to provide supply to the frontalis. Here, it's very deep, a centimeter and a half above, it becomes superficial. Now, can you wrinkle? Let me get rid of this. Yeah, no, you can wrinkle. Okay, that's
And while
all right.
she's doing that, remember from the forehead and scalp anatomy, remember there's a few important layers. So if you're thinking about galea and you're not remembering that, think scalp, think SCALP, right? So there's skin, and then underneath the skin, of course, there's the subcu, the little adipose, and then you've got your skin, you've got your cutaneous layer, loose aponeurosis, and then you've got your periosteum, right? So SCALP, so the skin. And then we're going to have, of course, the galea, which is going to be in the middle portion, loose areolar tissue, and then periosteum, so scalp.
Okay. So when she frowns, 8 to 10 millimeters medial in this crease is where the supratrochlear lies. Now, the supratrochlear does the same thing. It comes over the orbital rim. It courses superiorly with little collaterals, and a centimeter and a half above the orbital rim is where it also pierces through the galea and becomes more superficial. Now that means that this area from the mid-pupillary line all the way in this area, centimeter and a half above, to the mid-pupillary line, this is a no-fly zone. That means this is a danger zone. Why is it a danger zone? Because if I get so bold as to do a deep injection here into the supraorbital artery, it anastomoses to the ophthalmic artery, to the central retinal artery. You are talking potentially instantaneous irreversible blindness. So this area right here, you have to be very careful. Now, if I'm using a neuromodulator here, and someone has etched lines at rest, adynamic lines, then if I inject intradermally, and I know I'm intradermal when I feel resistance on that syringe as I'm pushing, right? Because think about it histologically. The dermis is very tight and dense. So if all of a sudden it's easy to push, I'm too deep. So I can inject here if I'm very superficial. I just have to avoid depth. Now, if I feel that I have to have some filler in here, if I come perpendicular to the vessels with a cannula, even if I go through that vessel as I'm injecting. And I know this is going to sound shocking. I don't aspirate. I keep a moving tool, whether it's a needle or a cannula. I have it moving. So if I go in that vessel and have a little small injection, I'm not forcing the product retrograde or down into the ophthalmic artery. I can go across with a cannula. The other thing is, as I come more superficially, if I want to inject and revolumize the forehead, which helps in many of my mature patients because I'm limited on how much neuromodulator I can use up here. They need their frontalis to pull those eyes up so they can read, right? In order to minimize the amount of neuromodulator I need, if I come perpendicular, deep on the bone with my injections here, I can revolumize that. It will push out from underneath the muscle against the frontalis, making those etched lines effaced. So I often will use even 0.3 of maybe a blended product because I want it to go evenly underneath that galea, and I want to come just perpendicular, deep. So this area right here needs to be a deep injection. And if I'm injecting and etching those, that has to be a superficial area. Now, one other important anatomical landmark in the forehead is the temporal fusion line, the temporal crest. You can all palpate your temporal crest. So here's the temporal crest right here. And why is this important?
Let's get her rotated.
Oh, sorry, I'm pulling her this way.
No, that's fine.
No, you're right.
Just
okay.
Scoot just
so here's the temporal crest. What's really interesting is that the supraorbital artery comes out of this foramen. Now, usually, they like to hang together, arteries and nerves. In this case, not so much. Supraorbital artery comes out and then tracks laterally. Usually, I overdo that a little bit, but 8 to 10 millimeters medial to the temporal crest. The reason that's important, this nerve, supraorbital nerve, lies deep. That means you don't want to inject deep, right? Because if you hit a nerve, what happens? It hurts. Arthur says, you pain them, you won't retain them. So do not inject deeply here. If I need filler here, I will inject medially and blend it laterally. So I try to avoid that supraorbital nerve that I don't hurt them. Any thoughts on that forehead area?
No, I mean, everything that you said through there makes total sense. And we're going to correlate this with our, digital version of all that in a little bit in the anatomy. But I think everything you mentioned makes complete sense. And I would agree with it, sort of in through this area in particular. We know that if we need to be so bold as to do some fillers in this area, they must be small aliquots, low G prime. We'll talk about what all that means in a little bit, but extremely superficial intradermal type injections. You also almost see the needle tenting through if you're going to be working in here. So you have to use something that's not going to tindle, and you want to work with a product that's not going to cause a lot of water absorption because we don't want swelling. We don't want compression in through here. Remember, these nerves, arteries, and veins are exclusively responsible for blood flow to this area as well. So there's the catastrophic issue, of course, that could occur, which is blindness. But even on a more concerning, but typically not as catastrophic level, is if you get compression or injury to those vessels here, you can cause congestion, venous congestion, or arterial compromise and blood flow to the forehead and to the scalp. And certainly if you injure them, just like you said, they are going to have shooting pain going right through their scalp because there's a lot of arborization of those nerves in through that area.
Now, one thing I'd like to add. I'm a cannula girl. I use cannulas and needles. Don't think you can't hurt someone with a cannula. A very experienced injector, all right? Not a side, just a very experienced injector. This summer, blinded someone, a 31-year-old girl. She came with a 23-gauge cannula, superior to inferior, with a filler, and managed to give an intravascular injection to either it was the supraorbital or supratrochlear with a cannula. Many cases in the literature, there have been over 100 cases now of blindness globally, and many of them were done with cannulas up the dorsum of the nose, because in Asia, they do a lot of nasal filling, and what happens is they come up. There's actually a case in Thailand where a plastic surgeon blinded his wife bilaterally, his own wife, coming up the dorsum of the nose with a cannula. Must have been able to get both supratrochlears and instantaneous irreversible blindness. How many people have blindness in your consent form? Good. You must. You have to. It's on television. I just heard one of the ads for one of the filler companies, and on television it said blindness. So that's really an important thing to understand. What we're doing has serious potential adverse events, and that's why you have to understand the depth of these vessels. Now, let's go along here and talk about the superficial temporal. The superficial temporal artery comes out in the pretragal region and courses superiorly. This is the serious problem in the temporal region, which is why, if you're going to inject superficially here, I do think you're safer with a cannula. I think you need a cannula. I feel the safest way to inject here is to go a centimeter up and a centimeter down. So if you come to the temporal fusion line and you go a centimeter up and come a centimeter down into the temple, exactly perpendicular, half-inch needle with a high G prime. Because what happens here is, here's the galea on the frontalis region, okay? And that galea, as it comes laterally, becomes the temporalis fascia. It's your friend, because it's a tent. That temporalis fascia holds the product down, and you're injecting under the muscle. This temporalis muscle is tight to the bone. So it is really, you're right down on bone, and don't inject, you don't have to push too hard. You just tap the bone, know the placement of your needle, use a high G prime product, and inject very slowly. I inject holding my thumb here because I don't need to revolumize all of this posterior portion of the temporalis fossa. I just need to soften the skeletalization, that orbital skeletalization when you lose volume in the temple. Now, why is this superficial temporal and the frontal ramus branch such a problem? Because as it comes medially, it anastomoses to the supratrochlear. So if I manage to push product into that superficial temporal artery and push it medially, I can get it to the central retinal artery. Now, when I'm going perpendicularly, I prefer to avoid it. Sometimes you don't. And when I remove my needle, if I see punctate bleeding, and I might have pierced it and gone through it, all I do is hold pressure. You cannot be in a hurry. You want to bruise them? Don't hold pressure. If you just take a few extra minutes, talk amongst yourselves, say, look, we're just going to hold a little pressure here for a minute. I don't want you to bruise. I never stop anticoagulants, by the way. All of my people are on anticoagulants. My people, they have thin blood. And so we're just going to hold pressure. And I think that's really an important area that you can do, quite frankly, more safely than you can the piriform fossa. So now let's talk about what happens down in the midface. We know that the transverse or emerging artery comes here. One area goes deep, more inferiorly. Here's the transverse emerging. Now, this is like an end artery. It doesn't connect anything. It's not a problem. If you inject this, it's not really going to be a terrible problem. It's not going to connect to anything that's going to blind anyone. The problem is it has little collaterals that come off. And sometimes even when you're doing Botox, you're managed to nip one of those. So you have to be careful. If you see that punctate bleeding, even with Botox, you can bruise people. So holding some pressure there is quite helpful. Now the real danger zone, again in the midface, has to do with the anterior medial cheek. If you look straight ahead at the medial iris and drop a line 8 to 10 millimeters below the orbital rim. Here is the infraorbital foramen. Okay, and in this out of this infraorbital foramen come the infraorbital artery and nerve. And what happens is we don't always know the depth of these vessels in this area. Also, coming off the facial artery is the angular artery. Now, this is a scary little bugger because this artery, the textbooks always showed us it was right at the base of the nose. They lied. The Koreans showed us that 31.6% of the time, this little angular artery is as far lateral as the infraorbital foramen. So I don't know where that vessel is, and I don't know the depth of that vessel. For that reason, when I am injecting in this anterior medial cheek, I think it is cannula country. This is where I feel safer with a cannula, because this angular artery, anastomosis to the supratrochlear, and we know is the roadmap ophthalmic central retinal artery occlusion. So this is cannula country. Here I can go superficial or deep. I often like that perpendicular approach. I do little Hershey's kisses. I go down, feel the bone, and come out retrograde. But I'm very safe. Even if I go through that transverse artery, I don't think it's a problem. I may bruise someone a little more, but it's not dangerous. Now, coming right along, if you grit your teeth for me, all right, right at the margin of her masseter comes the facial artery. Now, the facial artery, let's go like this. The facial artery we know is very tortuous. And why does it have to be that way? Because it's a thick-walled vessel. And when you open your mouth, if you didn't have a tortuous vessel so that it could stretch, it would shear because it's such a thick vessel. It's usually about 1.5 centimeters medial to the oral commissure. And then it lies very deep on the buccinator, the muscle of mastication. So this vessel is deep, which is fortunately why we don't hit it very often. And then comes the facial vein. And the facial vein is straight, posterior. And this facial vein doesn't have to be tortuous because it's a very thin-walled vessel, again, lying deeply. So in this area of revolumization, I often will pinch the skin and inject more superficially, but truthfully, these vessels, fortunately, are deep and not a terrible problem and risk. And then off of the facial artery comes the superior labial and the inferior labial. Now, why don't we see more necrosis around the mouth? These vessels lie deeply, and these vessels have lots of little collaterals. So even if you did get a little intravascular injection, there's a lot of collateral circulation. So due to the depth of the vessels and the collateral circulation, that hasn't been a terrible problem. Now, in the chin, the mental foramen, all the holes in the head line up, and that means that the mental foramen is just in line with the supraorbital, infraorbital, and mental foramen here. But again, most of these vessels are good with collateral circulation, so this hasn't really been a very high-risk area for intravascular injection. I often will inject exactly inferior on the bone here and have had no problems in that area. Again, even if I'm revolumizing this mandibular sweep, if I make an entry point and I happen to have a little bleeding from that facial artery, I can actually stop the bleeding with pressure and then with a cannula go posterior and medially without a risk to that facial artery. Thoughts?
So I think that's an excellent topographic review of all the pertinent injector anatomy in terms of keeping patients safe. Only thing that I would just add to is that along with, because she was talking about vessels, which are obviously very important, this will come in play a little bit later on tomorrow, which is, remember, with that facial artery and facial vein at that antegonial notch, we have that marginal mandibular nerve. So we were thinking earlier about Kybella being out further laterally, thinking about treating the jowl. That nerve comes right through there and goes those lower lip depressor muscles. So I think that's an important component. As you just said, it's rare that we have issues with the mental foramen. If you're trying to do a nerve block because you're going to do a lot of work in that area, that's an intraoral injection. It's not necessary, but that's something that's done intraoral. And bigger picture is unlike the infraorbital nerve, artery and vein, which pierce through the skull base anteriorly. And if we look at the notch, the antegonial notch, right? We all understand why we have a notch. It's because, if you feel your own, if you rub your finger along that posterior portion, you have a notch there because basically from birth or embryologic development, 80 to 100 times a minute, your artery is beating and pulsating against the bone, so you get a little bony resorption. So we have an antegonial notch here because that's where that facial artery keeps pulsating against the bone. So that comes right in through here. This mental nerve foramen is very much on the anterior portion of the bone. So unless you are going down onto bone, onto here, which there really is rarely an indication to be this high on the bone, you may want to work in through a little bit of this sort of chin-cheek junction or work through the oral commissure. That's a much more, in deep mid-dermis, deep dermis area. You're going to be completely fine because that nerve and artery are literally coming out of the bone, and that's something we do for a dental block along with it, inferior alveolar nerve. So just minor tweaks, but that was, excellent. So.
Now, I would say this is not a Picasso drawing, obviously, but you're more than welcome to take a picture of this. And the reason I'm telling you to do that and asking you is that I want it imprinted on your brain. I want every time you take that syringe and you go in a face that you think, what's under the skin? What is the depth of the vessel in that location? And I will assure you, it will keep you safe. And whether or not you're an aspirator, that's your own comfort level. I can tell you a little study that we did. We put some of my blood in a test tube and decided to try to withdraw. It is not a flick. And if you think you're aspirating with a flick, it's actually difficult and takes firm, steady pressure. So don't give yourself a false sense of security with aspirating. I would propose you think about a moving tool that's not going to stay stationary and give a big bolus unless you know where you are on the bone.
So I'm going to take us back a step, and we're talking about facial assessments, facial anatomy, and all these components. I think it's really important for us to think fundamentally and philosophically where our journeys with these treatments start. So yesterday, we really had a nice chance to hear from you about how you mentioned, being involved with collagen studies, and we finished, that component, and where things have grown from there. When I think about it as a surgeon, from my perspective, about where my journey with injectables has taken me, or where I've started, and why I, as a surgeon, really like to inject, it's really thinking about kind of how the nature of all these treatments have evolved. So if we think about the upper third of the face, right? And historically, if a patient came in with some very deep rhytids in the forehead, vertical ones in the glabella, and had some crow's feet, had a little bit of brow ptosis, and we're going to do another facial assessment a little bit later. Historically, the treatment in order to treat this area really was basically a brow lift, right? You could do a coronal brow lift, which is in front of the tragus, across the entire hairline all the way here, peel the forehead down, strip out and do a frontalis myomectomy, strip the corrugator muscles off of the supraorbital rim, all in an attempt to get rid of some lines, creases, wrinkles, and get a little bit of brow elevation. What could result? Paresthesia, numbness, other concerns with vascular compromise, certainly contour irregularities with missing a square patch of muscle, and then recurrence, as it all would kind of scar back in. So it's a pretty long run for a short slide. That has evolved to an endoscopic brow lift, temporal brow lift, anterior hair brow lift, and there's no substitute for a well-done brow lift when a patient truly has such intense elements of overall brow ptosis that they need to have that procedure. But by and large, the way that we started to treat and look at the upper third of the face dramatically started to change in '02, and even a little bit before that. And what was so special about 2002? Susan would know, because she's probably part of a lot of that.
Restylane.
Well, I was going to say, before even 02, I would say Botox Cosmetic gets its FDA approval, and then, of course, Restylane right behind it with the volumization for the next part. So all of a sudden, Botox Cosmetic gets its FDA approval, and the way that we looked at the upper third of the face has never been the same. Right? We now know that patients can come in and in a few minutes get rejuvenation of this area. They can have slight elements of brow elevation, and what we used to do with the scalpel has now been supplanted by what we can do with the syringe. And so then that got me thinking a little bit. So that happened at that early era in life. So we had a good non-surgical option for the upper third. But what about the middle third of the face? So where I practice, and even when I landed and was cruising around Fort Lauderdale, if I look around outside and I'm watching and we're thinking about something in the mid-face, often I look out the window of my office, I'm looking at Central Park, and I see someone walk by, a little old lady scurrying by. And I'm like, wow, she's not running, she's not sprinting. I look at the treetops, and those aren't blowing very hard. But her face is all the way back here. And she's, moving along like this, and I'm like, okay. And down here, we missed the hurricane, which is good. So there's no one, as that's not blowing, I don't see palm trees falling over, but I see a lot of people pulled very tight. And I think what we realize is that historically, in the mid-face, we thought that a youthful face was a tight face. But at the end of the day, a youthful face is the appropriately volume restored face with the correct skin and soft tissue envelope redraping over it. It's not that we need these tight, trampoline, snug, pulled faces that show youth. That just looks like a strange or old person, right, when they get pulled that tight. A volume restored face, a youthful face, has the correctly incorporated amount of volumization. And strategic, consistent, and predictable volumization happens with things like what Dr. Winkle just said, which is just a couple years later, which was the introduction advent, things like Restylane into our practice, Voluma, HA fillers, and how they started to be able to create structure. They weren't just one product. As we said earlier, we've got 13 or 14 now on our shelves or in the cupboard, because we can do so many unique things by understanding those principles to rejuvenate the mid-face. Now, we see a lot of patients also that look like they are suffering from filler fatigue because they've got 20 cc's pumped in their face, and what they actually need is a well-performed facelift, neck lift with good skin care and a chemical peel or laser resurfacing, because that is what is going to give them the structure and the volumization they need. So it's all about patient selection. But at the end of the day, we now know that not every patient needs to have this facelift at that point when they may just need a little bit of replacement of volume restoration.
There's one thing I'll add about what you just said about that person's got too much. Mm-hmm. It is interesting because we used to think it was just neuromodulator that impeded muscle movement. Mm-hmm. But quite frankly, if you get overzealous and you put too much, especially a stiffer HA in a face, you may have stretched out the wrinkles, you may have filled the valleys, but they can't move. They literally can't move. I kind of been there myself. I can tell you, I'm the Betty Ford of fillers, and I know there have been times when my very gracious girlfriends had put too much in my face. Number one, I was a bowling ball. I had no angles. Number two, I found that not only was I Asianized, what happened to my smile? I could not push it out. I couldn't smile. I didn't have any wrinkles over here, but it does impede muscle movement. So I think that you have to realize, with all of that we're going to talk about in the next 2 days, is that it's a matter of balance, that we don't try to give that person the injectable facelift to the point that we've impeded their muscle movement. They can't show any expression, Their grandkids turning 2 and they can't even look like they're excited about it. So I do think that making people not look weird is absolutely imperative. because we are our own worst enemies. We're the ones that'll kill the market. Commoditization, all of those things. If we make these people look weird and try to get greedy with what we're doing and don't keep them in balance, age appropriate, ethnicity appropriate, all of those things, then we're the ones who are going to kill the market.
Great comments. So I think, again, as we think about my journey or think about our journeys with these, we've had great options in a non-surgical arena for the upper third and the middle third. And again, I'm a surgeon who loves to spend his days in the OR, operate 2 to 3 days a week, and love to inject as well. But patient selection is so important. We started to think about the advent of what could be done for the lower third of the face. So we know that, again, we can use fillers in an appropriate way for contouring of the mandible and the jawline. But what had really been missing for the longest time was a non-surgical option for fat, for example. And that's what got me really excited about Kybella. It led to about 3,000 treatments that we've performed now on hundreds and hundreds of patients. And basically, I started to look at non-surgical modalities complementing surgical treatments and where that journey will take us. So I think we really need to be thinking about the full face. For example, when we saw our patient who was kind enough to come up and let us draw, we noticed immediately that we were looking at different components of the face for harmonization and to keep the patient looking like themselves. We can't get focused or tunnel vision. So it's taken our journey of what I used to think is this sort of concept of an annuity, right? And that's what these treatments often are, is that they're over and over and over again. But at some point you have to think about, are we taking them to an end point? Are we taking them to a certain goal? Are we doing maintenance? And rather than thinking about this being over and over and over again, which can often be the case, is, I say that we have a social emergency at, January, another one by April, another social emergency, and they just keep coming back repetitively. Or thinking about a full face assessment and a little procedure and actually taking patients to the finish line. My team found this little GIF, and I could just watch it like all day. This little guy, I just don't know what about it makes me so happy, but you just watch this guy over and over again. We probably lost about 5 hours of productivity with the team just like coming in my office and staring at this. But anyways, it's just kind of a cute thing because we want to get people to a finish line. Think about these treatments like a procedure. Interestingly, if I look at last year's ASAP statistics, American Society of Aesthetic Plastic Surgery stats, in this country, 86% of the patients that came to our practices opted for a non-surgical aesthetic treatment. So for me as a surgeon, again, thinking about what my patients need, what my patients want, I need to understand what it is that are the appropriately selected treatments for the appropriately selected patient. Now, I can't just listen to a patient tell me, or I don't just tell them that, no, you have to have liposuction. They may actually be opting for something, and as long as they understand what the value or the difference is, whether it's a cost issue, whether it's a downtime issue, whether it's a repetitive treatment issue, whether it's an efficacy issue, understanding what the treatment does and being transparent with the patient leads to a much better outcome. Because patients are coming in and they want to often have non-surgical treatments. And I think about this as the holy grail. What's sort of the holy grail of aesthetic treatments, right? It's the treatment works very well, right? High efficacy. Patients want no downtime, right? It works really well, no downtime, lasts forever, is performed by the most experienced person in the world. You got to do it because you know how to do it. And by the way, can it be free? Right? That's what patients are looking for. Obviously, we know it's not going to be free, but the holy grail of a lot of these treatments are high efficacy, longevity, and helping these patients get a good outcome. So we have to know our science, have their data, but these numbers don't lie in telling us what patients are coming to the clinics looking for. And the growth rate is 2.5 times faster per year in these treatments. So, I'd love to get your take if, over the last 5 years, 10 years, 15, let's say even 20, what have you seen as far as the marketplace changing or growth rate of these treatments, for you? Because, again, being involved for the time that you have, you've seen a lot of trends come and go.
I think it's amazing. Quite frankly, my marketing budget in my office, zero. I actually do put an ad occasionally in the ballet or the opera or the symphony because I like those. But literally, it has grown itself because that bridge club, when they go back after I've treated them, they're like, well, the ones that'll tell, oh, Dr. Winkle did this. And I think it's because people feel so much better. I mean, Steve Diane's written numerous articles about self-perception, overall happiness. We know about depression. It improves depression. So I think the fact that it's achievable you don't have to be a billionaire to come and have these treatments. We can tailor them to fit people's needs where they get the biggest bang for their buck. And so I really see that the market's exploding and growing itself. Truthfully, we've really only tapped 8% of the market that really is out there and can afford it and wants it. Do you know what keeps people away? It's not money. It's what I just said, the fear of looking weird. People sit in my chair every day and they say, I just want to still look like myself, Dr. Winkle. I want to go home, and when my kids come down, I want them to know that I still look like their mom. And I think that's what we have to recognize, that if we will just utilize these tools in a gradual way to improve how people feel about themselves, they can afford it. Now, men are a little afraid, let's be honest. They're a little on the more scared side. I think pain is a variable that keeps men back sometimes. But I do feel used appropriately, this market's going to just continue to explode and grow itself.
Yeah, I couldn't agree more with you. And it's great observations over over that span of what I was mentioning. And I think Bob actually brought that up really well yesterday when he was giving his talk, talking about that considering what market penetrance is, there's enough to go around. We're still looking at 85 to 90% that's not even tapped. So thinking about where there's opportunity for us to grow, there's more than enough for everyone. We just have to do it at a really high level. And I often think about the people that are here on a weekend really aren't the ones that need to be here. Because you guys were the ones that were in the front row in nursing school or medical school or PA school. It's our peers and colleagues who didn't show up this weekend who are doing whatever that don't really want to learn that are the ones that end up making a lot of critical errors that then set the whole field back. So it's really a function of understanding safety and outcomes. The full face is such an important component to our assessment, though. And I want to do a little exercise with you on a very iconic image that exists, and I'll show you what that image is. But if we think about the full face and just looking at this image of this individual and see what we kind of get out of this component. So here's the upper third of this individual's face in this image. Here's the middle third. Not much to really show. And as we start working our way towards the lower third, this is what we have is just these lips and this beauty mark. And when you put it all together, this is an image of an individual named Jean Patchett. And for those who don't know the name, was basically graced the cover of 1950 Vogue, which is considered to be one of the most well sought out images of beauty of all time. And Jean Patchett, who was photographed by Erwin Blumenfeld, had more images in Vogue than anyone in the history of photographers for them. And what he did was he used light in the lab to erase all of the different, and remember 1950, so he was in the lab and used light to paint out other elements of her face, but wanted to keep iconic components of Jean Patchett's face, who was sort of the Naomi or Cindy or Iman of her era in that time period, and keep very specific, iconic portions of her face in there. But when you put it all together, this is what you're able to see, but even with her missing the components of her mid-face. And this is where he had started with this image. So I was really excited when I had renovated, rebuilt, and did my new office. There's only about 10 prints of this available, and I was fortunate enough to secure one through auction and get one in my office from the original estate. So it's a very iconic image. But again, what's in a face if you're not looking at the full face? Is you could be missing critical and key elements when you're trying to keep someone's face balanced. So it's really all about making a diagnosis and looking at the upper, middle, lower third, submental area, and thinking about the face being hairline to clavicle. And that's an important part of a facial assessment. And what routinely keeps us from doing this, I find, are that we are often afraid to make a diagnosis of what I like to call aesthetic pathology. Right? My father's a cardiologist, and a patient comes into his office who's suffering from a lot of different issues. He lets them know that they've got uncontrolled diabetes, that they have hyperlipidemia, that they have uncontrolled hypertension. He doesn't sit there and think to himself, I'm not sure if this person can handle knowing that their hemoglobin A1C is a little high. I'm just going to leave that out today because I'm afraid. Right? He makes a diagnosis of what's going on for this person. At the end of the day, we still practice clinical medicine. These are still our patients. And so why are we often so afraid to do a full face assessment and say, these are all the things that I see. I see these glabellar iridids. I see these crow's feet. I see midface loss and ptosis in this area. I see a prominent tear trough. I see a nasolabial fold, which could be improved without injecting it by doing midface. I see a jowl, X, Y, and Z. You create an entire list and diagnose them with their aesthetic pathology and not hold out on them because we're concerned that maybe they can't afford it. Maybe they'll be overwhelmed. They're in the office because we are their experts, right? They're there because they read about you, heard about you, take care of their friends. You're highly regarded. This room right now represents some of the finest injectors and colleagues and doctors in the state, in the country, which means in the world. So why are we so afraid when a patient sits in front of us to give them an entire diagnosis of everything we can do to help them? Just like my dad's patient could walk out and say, fine, I'm not sticking that insulin in my stomach every day for the next 30 years. Your patients can walk out and say, you know what, that sounds great, but I'm not going to do that jawline filler or that Kybella, or I'm not having that Instalift, whatever it is. It's up to them. But they at least leave our offices with a plan and with an understanding of what's possible, because we have to be full-face injectors, or full body. We have to look at every component and create a diagnosis of what I like to, again, call aesthetic pathology. Any thoughts, Susan?
I think that sounds right on. And we can't judge a book by its cover sometimes. Someone will walk in and I'll think, well, I really shouldn't tell them all this because it doesn't look like it's in their budget. Well, maybe they just don't like nice clothes. I mean, but they really have a big budget. And so that's why I think we don't want to underestimate what someone might be thinking. But that's why I also sometimes start with that mirror to say sort of, what are you thinking? And then do the full face assessment and tell them what are the possibilities. And sometimes it just surprises me because I'm shocked to think that person's willing to spend, $3,000-$4,000 today when I would have thought maybe they might not spend $300. So don't underestimate and give everyone that fair assessment. And I think that's really nice terminology to call it the aesthetic pathology. Although pathology does sound sick. I don't know.
Well, we don't have to tell them that they have pathology, but for us as clinicians, certainly, okay. I think that's fair, right? So actually, in the same vein of earlier, we saw really great topographic anatomy, and I think it's great to use tools that we have to really show anatomy. And so we saw how it's correlated through there. But one of the tools and instruments that I think has been a really exciting introduction, and some of you may have seen this, and many of you may not have, is Lucy. So I think, again, some of our industry partners like Galderma have created amazing research tools and teaching tools for us. And I think it's great to correlate what we spoke about earlier with a 2D, but that also has the ability to be 3D, but we don't have that functionality here this time. We'll have it in the future. But to understand some of these anatomic areas. So what I want to do is a very top-line discussion of some of the anatomy that we pointed out and look at it together. First of all, I think our assessments, when we're looking at patients or thinking about patients, really need to be done at a few different ways. We need to be doing an animated type of assessment. Just like Dr. Winkle said, when she's in the room, she wants sometimes video capturing a patient, and we're looking at different things that patients can do. I'm big on looking at patients with a closed smile just to see how their natural lines or how they pull. But an open smile, I think, is also very important because that's where we can see how's the risorius playing with the superior labii as well. How are all of these different muscles engaging and interacting? When we grimace, we can see a lot of pull in the lower third of the face as well. So I think that's an important component because we're activating those other facials of animation. Pursing the lips helps us accentuate the tubercles, helps us look at perioral rhytids, helps us look at mentalis strain. So again, a lot of really key elements. And then, of course, in the upper third, you have the ability to furrow, raise the eyebrows, and when you smile again really big, you can also look at activations of those muscles. So I think we need to be capturing dynamic images because we don't live in a static world, right? Over here, I wasn't, the first morning I woke up here in Florida, it took me a whole 15 seconds to look outside and want to take a picture with the beach, behind. And when I'm in New York and people are walking by, you see everyone with the selfie stick trying to get that perfect picture. And we take 50 photos and then keep one, and that's the one that then gets edited and posted and everything like that. We live in a very video and dynamic world. So static images and static assessments are not ideal. Are there any types of tricks or things that you do for your dynamic photos, or is it kind of just in that capacity with some of these basic facial assessments?
No, I think that's spot on, but we also make sure that we do it at different angles.
Yes.
And it can't be just dynamic in the frontal view. We actually ask them to turn and see the different sides, because you're exactly right. Sometimes that little risorius muscle is over-engaging, or there's an imbalance in muscles. Just because you have the muscle here and the muscle here doesn't mean they're working the same. Sometimes you'll notice that actually, even again in myself, I notice sometimes when I smile, and even when I was very young, my depressor labii on my right side is a little hyperactive. And so because of that, I had a little more tooth show. But you wouldn't notice it unless you see me speaking at times, and, well, it's fixed right now, okay? So you're not going to notice it. So I actually intentionally inject my depressor labii to give myself balance. But I wouldn't know that unless I actually watched that video. And then sometimes when I take a very big smile, I can see that that's pulling down a little bit. I say, oh, okay. And then, of course, I put too much, and then I bite my lip for a couple weeks, So more is not always better. I've learned that I just need one unit, but then, of course, one unit doesn't last very long. And so I think those are things that you notice by looking at the dynamic face from different multiple views.
Agreed. Great. So if we start echoing what some of the anatomy was earlier, and let's look at the forehead, for example. I'm going to go ahead and start to zoom in here at this area. One of the things I think that's really interesting is we got to look at the relationships in the anatomy. So we're just going to, again, lift this up and start to take a look at those vessels that we mentioned in some of the muscles here, right? When we look at what we're trying to treat, we have our procerus, and we can see as it kind of shadows in, our corrugators, which are deeper. And I think what you had mentioned earlier was the pathway that a lot of the vessels take and how they can be, deep to these and are in this area quite deep in that region. So you want to be a little bit more superficial with your injections. We have our depressors, and this will all come in handy later when we're doing our live injections. So again, just thinking about the pathway and how they overlap that supraorbital artery and nerve in the supratrochlear. You can see those vessels that are bundled here, and when we sort of rotate her, we can look at those three-dimensional relationships and how they do track back to the orbit. Just like you said, you can see they're shadowed in here, and those will start working their way down. So this area is very important, and we think about, again, those supraorbital vessels that Dr. Winkle drew out earlier, going right out through that notch, through the supraorbital notch, as it gets a little bit more lateral, closer to the medial portion of the medial limbus. So you can just see some anatomy in this area and look at some of these spatial relationships that we find in this region. The frontalis itself is very closely adherent in this region. It's a bit more superficial of a muscle, so we're looking at the deeper muscle structures here. If we start looking at, just to again clinically correlate some of our other anatomy from earlier, and we look at our midface. There's a lot of discussion, of course, about midface. So when we get into the midface and start talking later about different areas that we want to treat, again, very similarly, we need to be thinking anatomically. When we peel that layer of the skin back, right, we're now starting to look at some of the SMAS, which is a superficial musculoaponeurotic system. Below the level of the mandible, we know that SMAS becomes contiguous with the platysma. So we want to be mindful in knowing where these spatial relationships anatomically are, but we can also see that highlighted in are all those fat pads that we're going to want to be replacing. Right? We've got our inferior inframalar pads, the nasolabials, the superior and inferior jowl, which we talked about earlier. I'm going to just give you a little bit of a rotation. We'll look at that on the jawline. And then the middle superficial, and then this lateral temporal cheek pad is also one of the ones that extends lower that we were talking about earlier with the post-facelift deformity, for example, when we see on patients that could often be manifesting with volume loss. So these are those superficial fat pads that we're wanting to replace with our HA fillers and their spatial relationships. If we peel that SMAS down, now we're really starting to look at a lot of important vessels. So here we can see that transverse facial artery that Susan had drawn out as that terminal branch as it starts working its way, but some of those branches will anastomose with the angular. We've got our facial nerve, which highlights so well coming out from beneath the mastoid as it all starts to branch. We've got those 5 branches, as we know. We have our temporal branch, our zygomatic branch, the buccal branch, marginal mandibular branch, and the cervical branch. So all of this starts to sprout and starts to work its way out.
So let me just ask one second. That terminal artery, some distal or more medial aspects of that actually do anastomose to the angular artery? Because I always thought it was a terminal artery.
Right, so there are a few branches which can then anastomose. I think it's well described that there are a few, it's a very rare occurrence, but I think we have to be mindful of the fact that there can be. It is not often. I think you do get typical termination of it, but there are some instances, so that's why we just have that. Nothing to the same extent, like you said with the Koreans that described so well what you mentioned with the angular artery being much more medial than we ever thought. It's not hugging in every capacity right along that nasal sidewall. You can injure it just like you very astutely pointed out. Our zygoma is such an important landmark. When we talk about mid-face injection, we want to stay often on the bone to be able to help rejuvenate that area. So we want to rejuvenate the soft tissue, but we have to be thinking about where these relationships are. So you can see the vessels often are coursing right along the zygomatic arch and to where the zygoma hits the maxilla. And then, of course, we've got our deeper muscles, and these are the elevators of the lateral lip or of the lip in general. So we've got our zygomaticus. These all help with our smile function, and you can see how they're oriented in this capacity. As we start to kind of rotate her through, this becomes a very important structure, which we talked about earlier, the infraorbital nerve. So when we're using that as a spatial relationship anatomically, we can see this is a very deep structure, but it is mid-pupillary, and it typically is going to sit 1.5 to 2 centimeters below the level or just below the level of the inferior orbital rim. But so that we can kind of see its orientation. If we look at her head on, I'll zoom out just a touch so we can see how this starts to basically appear. We can see that it is often very much mid-pupillary.
But many times, actually, I think that's a fallacy that it is mid-pupillary. Sometimes that infraorbital foramen is actually at the medial iris.
Mm-hmm. Right.
So the textbooks always told us it was mid-pupillary line, but in actuality, many times it's toward the medial iris.
Yeah. Agreed. There's always going to be some anatomic variance for sure, but I would say in that 2 to 3 millimeter range, no question. And again, you can see that it's really, once you peel back all the muscles, this is really coming out right out of the skull base, so to speak, or the skull itself. And then, of course, we've got our deeper fat pads that we can also just orient ourselves. When you hear about terms like the SOOF, you can look at the lateral and the medial SOOF and our medial cheek fat pads as well. So these were just some of those, again, visualizing this anatomy in this capacity when we're talking about it topographically. You can see that a lot of these structures that are concerning that we have to be very careful with are several tissue planes away from where we're planning on injecting. So knowing this can keep us very safe. If we start to look at the lips and the chin, I think this becomes a really important component as well because we're routinely treating these areas. We've got our tubercles that we want to often accentuate just to give us a little bit more volume in certain components, but definitely not overdo them. And when we open this area, we can see that there are several important layers as we peel back and wear those blood vessels. I think one of our colleagues in the front row earlier had asked about some of these lip injuries and lip injections. This will help visualize that. So if we start thinking about, again, our lips themselves do have fat pads that do atrophy over time. So you can visualize these. We have our lateral lowers, we have our central lowers, we have our uppers as well. And we can also see that we have our fat pads, including in the chin itself. Now, very importantly is the orbicularis, right? So the orbicularis oris is the muscle that helps us purse our lips. And those pursing over time can lead to those vertical perioral rhytids, which can be treated with small amounts of filler, be done very well with chemical peels for sure. They can be evased with laser resurfacing. So we have a lot of options to treat this area, but this muscle is the interface in which we want to be injecting superficial to it so we don't get as much swelling and bruising because we routinely will take our needle too deep. So this is important from that
and
capacity.
Neuromodulators.
Yes, of course.
I add a little neuromodulator up there. I think that is, again, a slippery slope. If it's a flute player and the symphony's playing Saturday night, you better not be injecting that person. Because I find that this is a challenging area for diffusion. But I think, again, that combination approach is helpful.
Perfect. So I just peeled back that layer. So earlier we had a discussion about what we're thinking with respect to our superior and inferior labial arteries. So what we're looking at here is, again, the superior and inferior labial arteries. When we reflect back the muscle, you've got it sitting on that posterior lining of the orbicularis. And what we're looking at now is the mucosa lining the mouth itself, right? Or the lip itself. So this is not the outer mucosa that we're looking at when we look at each other. This is the inner lining. So this is a very deep structure. But if you start to alter your injection technique and go intraoral or puncture way down through multiple layers of the lip, you're going to potentially injure this, cannulate it, cause a vascular occlusion, and this, of course, can also then travel as it does have its various anastomoses. So you have to be thinking about this structure. But to visualize it earlier when you had mentioned that whole concept, what you've seen on social media or different things with people having some major complications after a lip filler, which historically we do on millions of patients, this is where that is coming into play typically. In here, we're seeing kind of the marginal mandibular nerve a little bit. If we rotate her, we can kind of see how that starts to work its way up towards those lower lip depressors, and we can look at that on the other. And just to orient everyone, we've got the teeth in here just to kind of let you know sort of where that lip, where these fat pads are with respect to that. Mentalis can often be a little hot spot to inject if a patient has that sort of peau d'orange or all that really kind of wrinkling and up through and has dimpling in the chin. So that mentalis muscle is also a lip depressor. But those are pretty central. So people often will inject more laterally, and they're getting usually your DLI or DAO when you start going further laterally. That central chin really is pretty well consolidated between what we call those central incisors. So look at that sort of orientation here of where the muscles are and how they're oriented. This stays really close within those few teeth. So I'm routinely looking at patients' teeth to orient me when I'm also trying to inject to stay anatomically close to the muscle I want, knowing very well that there can be a lot of variation.
Speaking of teeth, I do frequently, gently, suggest that they might need to do a little tooth work because, that's very important in their smile. And you can do all this work, and then they open their mouth and smile, and they really need to go see the dentist. And so I think that sometimes it's brave. You have to go gently. And before you start blurting out that, for God's sakes, could you do something about these teeth? And no, but then I tell them I did the those Invisalign things, and it wasn't fun, but it is helpful. And I think it's about caring and treating that whole package of the patient.
Because you're making a diagnosis of aesthetic pathology.
Okay.
There you go.
Okay.
So here we have the mental nerve foramen. Again, you can see it's a very anterior. When I was orienting you earlier, how high it is. So you're quite safe when you're doing jawline filler if you're staying along the inferior border of the jaw. I'll show you a couple more cuts, and I think we're going to be ready to answer some questions, and then take our first break.
I do think she had microblading. Look at those brows. Let's call a spade a spade.
So let's take a look at that jawline, because this will be important for tomorrow. And we're going to continue to use Lucy throughout our discussions to, again, orient us anatomically. But if we start to look at her marionette and jawline, we peel this down. So reflected with this initially is also just the skin. And we know very closely adherent to the skin is the platysma. Remember, once we cross the inferior border of the mandible, that platysma becomes contiguous with the SMAS, which we may often want to replenish with volume in the appropriate location. So these are anatomically consistent planes. And there are still some build-outs that we're working on here, but I think what you can really see oriented here are the fat pads and where those sit. So we have our medial inferior chin. These are all of our superficial jawline pads. When we peel this layer back and we take the platysma down, now again we can look at our muscles, right? So we've got our DAO. Remember earlier, Susan mentioned that facial artery and vein. We can now see how it crosses the mandibular border at the antagonial notch, which is typically found just anterior to the masseter, which is one of our muscles of mastication. It's one of the muscles that we use to chew, right? We have the temporalis, the masseter, the medial and lateral pterygoids. So again, we've got our masseter here, and just our little notch as we kind of work our way up towards the anterior border of the mandible. And just to kind of, again, highlight our masseter, which sometimes if patients come in with a little bit of fullness in that bimalar width, or bigonial width, we can inject some neuromodulator into the masseter to help slim down the face. Or if patients are grinding their teeth a lot, masseter is a very important muscle that we can often and safely inject to get them to just relax and not clench quite as much. And again, it will have a nice slimming effect if they've got a hypertrophied masseter.
However, in the mature patient, you have to go carefully, because if you atrophy their masseter, what's going to happen when it's not filling out that skin? All of a sudden, they get increased laxity. So those mature people, you have to be a little careful at how much you atrophy their masseter. They need it kind of holding things out.
So again, great absolutely. Couldn't agree more with you on that one.
See, if you came to Florida to work with me, I mean, you would see that mature people, you had to have a different eye.
Well, I think they spend about half their time in New York and half their time in Florida, so we're seeing them at some point during the year. Usually after they've gotten some good sun down here, so I'm jealous. The antagonial notch, again, right through there. You can palpate your own, and that's where that important facial artery, facial vein, and marginal mandibular nerve are going to cross over. And this is why when we talk about jowl injection, it's so important, because it goes right through this area. It's on the deeper surface, but there's no question that you are going to get sprouting and arborization of the nerve, that some of those fibers become more superficial. So the technique, when we discuss it in depth later, when we pinch, really pull away aggressively, we want to pull that fat away from those deeper nerves that have already kind of sprouted, so we don't end up with a lot of patients, or any patients hopefully, walking around with asymmetric smile for days to weeks or even months, theoretically. And then to close the loop, because we are going to do some hand injections later, we're going to do just a quick basic rundown of the hand. And then I'm going to because you're going to be talking about all things hand a little bit later, which is always an exciting talk. But just to kind of show our dorsum, if we think about the aging component of the hands as well, this can be a very safe and appropriate place to inject. We know that we want to be working on the dorsum of the hand. And when we peel back the skin, we have what we call that. We obviously have the dorsal superficial lamina, which I'll show you in a minute, which is what we're trying to replenish. We've got our important venous plexus here. Our natural injection zone is really from the distal wrist up to the knuckles. And we want to typically stay in those intermetacarpal spaces, because that's what's starting to really atrophy, is some of the fat there. And then, of course, our dorsal superficial lamina, which is just this thin film of fat that can atrophy over time. If one of the things is that you notice in general, this dorsum of the hand, I don't ever want to give anyone a false sense of security, but the important arteries and the components of the radial artery, the ulnar artery, those vessels are typically on the volar aspect on the wrist area. There are some important arteries like the princeps pollicis and one of the branches called the radial recurrent, which does cross over. But again, if you stay in the injection zone, which Dr. Winkle is going to show you later, you are definitely going to be safe because these areas are much more proximal. So they're much higher up on the hand and the wrist. So that's why we want to stay in this really safe injection zone. But again, you can see the ulnar and radial artery superimposed. These are on the volar surface. They're very superficial on the wrist, on this anterior volar surface. And we have our metacarpals and our carpals all just nicely highlighted here. And again, just thinking about our extensor tendons, these are deeper to the layer that we want to be injecting. So the hand is one of the most intricate and important structures, no question. We don't want to be doing deep injections. We don't want to be injuring any tendons or nerves. That could be a devastating issue again. So we really want to be staying in that superficial DSL or dorsal superficial lamina.
Do you ever inject the fingers?
I have not.
I have not either. I'm not a cowgirl, but I've looked at mine and several times wondered if they wouldn't be better if they had a little filler in them. So maybe come back next year. Stay tuned. I might get brave. Because we know the vessels are basically lateral. So if you did tiny little aliquots of a blended filler along the dorsum, you should, and small, because obviously we don't want a compression syndrome, right?
Correct.
We don't want to have it swell and compress, and that would not be good. But if you did it a little bit, because I'm telling you, we fix here, and then this is screaming at you.
Right. Well, you think about, exactly, just like you said, compression and all those types of issues, but less fingers means less jewelry and less rings, which means a budget. It's balling on a budget, right? So it kind of takes us back to that word budget.
Actually, I'm in line for a bigger ring, so we don't want to mess up the finger right yet.
Exactly. So after you get the ring. I
think it's something to think about. I think I'm just putting it out there. I haven't done it, and I just want you to know that that's how we go down these roads, and we go gently and gingerly with small little aliquots. But again, it's that same situation. You fix the couch, you say, oh, the chair's okay, it's going to be all right. When the new couch comes, the chair looks horrible. And so that's sometimes what we're faced with, this whole aesthetic harmony.
So I think that, this morning session was really all about you getting an understanding as to how we're approaching the patient. We have different abilities to create a lot of important changes, but all for us, it's all about restoring harmony and looking at the topographic anatomy and how that's pertinent to the deeper anatomy when we peel it back. Ultimately, there are really unique and special ways to stay safe. That's what we're going to be talking about a lot over the next, today and tomorrow. But bigger picture is a lot of these structures are actually much deeper than we think, and if we stay in the right area and do the right treatments, you can keep thousands of patients safe without any issues at all. So I think her drawings are what you want to be instilling in your mind, and I think a tool like Lucy helps you recognize that, oh wow, that marginal mandibular nerve is scary, and we need to respect the fact that it exists on that jawline, but I don't need to stick a syringe or volume right onto the antegonial notch. I could stay a little bit more superficial and go ahead and stay through the sub-Q and pick the right product, which we'll talk about later.